this is the basics. Now you're talking about a diagnosis of common arrhythmias. You can do it in the EP lab, but there are some subtle signs which you must have because you're talking about diagnosis. So you have a short PR interval, a delta wave, so you can think of WW. You have notched P waves, you can think of LV dysfunction. You have a P pulmonale, you can think of a COPD. You have a VPC which has a left bundle branch block and an inferior axis, you can think of RVOT tachycardia. You have epsilon wave, you can think of ARVC. You have a long QT itself, you can think of polymorphic long QT syndromes. Next slide. I can move. So before we start, let's give to a very basic configuration of what we are trying to talk. So narrow complex tachycardia, what we are trying to talk is about a regular or irregular. So once you have thinking of a regular, you can think of A more than V, so you're talking about a flutter or fibrillation. If you're talking about 1:1 conduction, then it's basically the whole talk will center around whether it's a short RP or a long RP. In a short RP, you can think of an orthodromic tachycardia. If you have an A on V, then for all practical purposes, we are thinking of typical AV Nati or a junction ectopic tachycardia. In the same vein, if you have a long RP, we are thinking of atypical AV Nati, a PJRT, or an atrial tachycardia. So I want everybody to focus on the short RP and the long RP part because that really constitutes the major part of this lecture. So what should be the workflow? You're talking about diagnosing it. So you start with observations in the baseline. Observations during our atrial and ventricular pacing. Observations during tachycardia induction. Observations during tachycardia, and then important, all the maneuvers. We're talking about entrainment, asynchronous VPC, and maneuvers during the normal sinus rhythm, parahesian pacing. So let's see the baseline interval. So you are able to appreciate in a person a short HV interval. So you're quite sure that you're talking about a pre-excitation. Here you can appreciate, see that line, you have a line where the V starts. You're able to appreciate that the V is starting on the blue line while your H is at the red line. So you have HV interval which is negative. So it gives you a subtle indicator that yes, in our EP lab with the ECG available, in this case, right have an antidrome tachycardia, so you're thinking about an ORT. I said the very most important thing is to concentrate on the flow chart. What are the intervals, baseline intervals, then we'll go to tachycardia, maneuvers in tachycardia. So this is again an interval where you can easily appreciate you have a earliest A during V pace in a C1, C2. So you're quite sure that you're talking about a left side accessory pathway and left free wall pathway. So again, this is just to tune your eyes. You have a HV interval which is negative in the first beat, and you have a HV interval which becomes positive in the second beat. That means consequently you have ablated the EP, you have ablated the pathway, and then you can see that the HV interval becomes positive. So this is the baseline. In an EP lab, per se, in a baseline you can have the observation only for a short PR interval. That means a WPW syndrome. So what are your observations during atrial ventricular pacing? So when you think of a pacing maneuver, you think of burst pacing, AES 1-2 pacing, ventricular pacing at different cycle lengths from different sites in your ventricular channel and the atrial channel, and then think of a parahesian pacing. So let's see atrial pacing. How do you do an atrial pacing? You pace from the right HRA. You can appreciate pre-excitation per se. That means you're doing a pace and you are able to appreciate that the manifestation of pre-excitation which was not there can come up because now you have pre-excited the A so as the impulse can reach the ventricle faster. You can have an AV crossover. That means your A gets so delayed in an AV Nati that you are able to appreciate that the first A is still giving rise to the V and the second A also comes. So AV crossover. You can have an AH jump, which is the classical thing where in our labs you diagnose an AV Nati. So you have an AH jump, that means you do a atrial pacing, you have a jump in the AH interval, and you are able to appreciate that with a 10 millisecond increase in our AES interval, you have a 50-second jump in the AH interval. Atrial pre-excitation, I said, can be excited depending on where the pathway is. Sometimes you're doing from an RV and you have a left lateral pathway, you might not be able to appreciate. But then, if you have a suspicion from the very beginning that I have a right free wall, go to the right free wall and pace. So you go as near as possible so as to induce a pre-excitation. So So AV naughty, the most important and the most bread and butter of EP lab. AH prolongation, AH jump, 1:2 response in a crossover. While in a AV NRT, you think of increasing pre-excitation. So very concentrate on this, on the red zones we have. So you have given an atrial extra premature. Can you see the line will tell you that this is the H in the previous one. And then this is the H in the previous one. This was the AH. And you see this is the AH now in the second. So with a 10 millisecond decrease in the atrial extrasystole, you see the appreciation of the AH interval which has increased so much. So this is the interval. So this signifies more than 50 millisecond dual AV node physiology and the basic area where a AV NRT will be induced. This is a little interesting thing, a 1:2 response. See, in an AV NRT, what is basically there is that you go from the fast pathway and come back via the slow pathway and come back via the fast pathway. If the retrograde conducting properties of in a normal person, the pathway which is used is a AV node, which is like a fast pathway. So the slow pathway ascends back, so we don't have a tachycardia in that case. Let's say there is no retrograde conducting property in the slow pathway. Then for a single A, you will have two V's. That means a single atrial extra stimuli is now sending V via the slow pathway as well as the fast pathway. That is an indicator that you have an AV NRT. So that's known as a 1:2 response. Now, you can see that is about the AV NRT. You can see the pacing response, as I said, for manifesting the pathways. So you have first a pre-excitation partial, further pre-excite, you have a further pre-excitation. So it's now fully pre-excited. And then in the third one, the effective refractory period of the node is reached, and so you have a loss of the AP conduction. Differential A-side pacing I very clearly mentioned. Pre-excitation can become apparent when you pace the pathway. Again, for the HRA, it will be for the right pathway, CS distal for the left free wall pathway, and lateral RA, this is for the Baham pathways. I think we should concentrate more on the ORTs and the AV NRT. So, this was a subtle pre-excitation. This is about the Baham pathway you're trying to capture, but you'll have short HV but subtle pre-excitation if you're pacing away from CS somewhere, because the pathway is mostly right side free wall pathway. And this will become much more manifest if you pace from the right side itself. Can you appreciate the fifth beat? Your HV has become negative and you induced LBB. But see, this is again differential side pacing. That means you had to go to another side to pace and then you were able to appreciate. Ventricular pacing. What is the basic thing? If you still have a VA block and you have a tachycardia continuum, that means you're talking about an atrial tachycardia. If you have a concentric activation, you're talking about AV NRT. If you have a concentric activation, you can also talk about a septal pathway. And in centric will mean an AVRT. Parisian pacing I'll explain later. So the pacing technique, pace either from the RV apex or base and look for the A. You have 1:1A is the A concentric or eccentric. VA dissociation you can appreciate here. For V there is A is going on its own and the V is going on its own. So your VA dissociation even at 410. So this practically overrules an AV NRT and ORT, because for the conduction system to remain robust, you must have a good conduction from V to A, and then only your pathway will be complete. Now this is a classical concentric activation pattern. Okay. So this is a classical concentric atrial activation pattern in an AV NRT because it's concentric. Your whole track is in the atria itself, the slow and the fast pathway. The ventricle has nothing to do with the pathway. And so, because there is no preferential activation of any part of the atrium, you will have all of them lined in a single line. That's known as a concentric atrial activation. While if you see here, you see an activation through a right free wall pathway here. So here you see that the his is coming earlier. Your A in the other, you can appreciate the A in the others is so late, while your A in the his earlier. Now this in fact is missing the right atrial pathway because you have not put in the HRA, the right atrial lead it also. Then only you will appreciate that it becomes even earlier than the his, because otherwise a normal person it will be the his which will be. So atrial activation pattern in a septal pathway, again it will be in the proximal CS. C910 will be early. What I'm trying to show is that your activation pattern on pacing the ventricle, the earliest activation which comes in the A makes all the difference to the pathway you're talking about. So this is the centric V again in a left side pathway. Can you appreciate that this distal CSA is much earlier? Just appreciate the blue line, and the A on the blue line is earliest in C1, 2. Bracketing. Now this is a phenomena where we have a left side pathway. You want to know exactly where you are. So you put, let's say your decapolar is at a particular position. Your C1, 2 is earliest. Now you push in your decapolar. Because you pushed in, pathway remains at the same side, so your 3, 4 will become earlier. This way you have bracketed the area where that pathway is. But remember, this bracketing can be done on left side pathways, but not in right. Because in left you have a mitral annulus, so there you can appreciate with the help of CS, but that doesn't happen on the right side. So as these are examples once again. If you are not close to the pathway, even if you are doing a V pacing. So let's say this was a left lateral pathway, you are pacing from the right ventricle, it's a concentric VA. But if you do it from the left side, you have an eccentric VA where you will have the earliest V in the distal C. So pacing sites important, concentric, eccentric, VA blocking. Now let's say you have induced the tachycardia. How do you induce the tachycardia? When you do an A pacing, you have an A jump and you have a tachycardia with set. But if you let's say that's about a AVRT and RT, let's say there is an atrial tachycardia. So your induction will have the A beat funds. So you have a VA-AV response. That means you pace the V, got an A, and got an earlier A. That means you have got an atrial tachycardia. While if you have a VA-V response, that means you have a ventricular. Now let's see, this is a pacing which I've just told you about the AH jump. Can you appreciate here? There is an AH jump, the AH prolongs. After that, there is a tachycardia which sets in. The V and A are in the same line. So it's almost a V on A tachycardia. So the tachycardia cycle length, your VA interval is hardly 33 milliseconds, less than 70. This is about AV and RT. That's the induction of an orthodromic tachycardia. You're pacing from the V, and can you see after the last pace beat, your VA-V response has come, but VA-VA response where the VA is short, but not V on A itself, not like an AV and RT, but like an AV RT. There you see at the earliest A is in C1, 2, so the left lateral. Same you can do for an antidromic tachycardia. Pace from the A. Can you see the pacing? First the normal. Third one becomes pre-excited B. Because now you have been able to induce the pathway to come into action. So these are, so going on a flow chart. Time, have some changes. Talk about anything. You are able to induce it, but good. Other maneuvers which you can bring tachycardia. But this is a little complex chart, so let's concentrate only on the left side. Neurocurous tachycardia, 1:1 AV. You will have AVRT, AVNRT. So you can concentrate on this part of the chart. The other part is also important where you have an AV block with or without a VA block. Talk about AVNRT because an AVNRT can exist with a AT or an atrial flutter. But the basic premises of today's lecture should be on the left side. One, our basic areas to cover are AVNRT, AVRT. Based on observations, if there is a spontaneous AV block during tachycardia and the tachycardia continues, that means it has to be AVRT is overruled because AVRT requires ventricular to be part of the circuit. Not the AV, the tachycardia cannot continue. So remember, I'll give you examples also the ECG. But this is a very big basic difference. Spontaneous AV block during tachycardia continues. So orthodromic AV and RT, AVRT overruled. Spontaneous termination with an AV block, that means AT overruled because you have a V block and the A has not come again. And development of bundle branch block, think of a Mahem. As I said in the very beginning, Mahem is one tachycardia which is the right free wall, you need to go close to the tachycardia zone. Increase in the V interval with the branch block. Let's say you have a tachycardia with V interval. You have an increase in the V interval. That you are 2 more time. That means if you have a cardiac continuity, lateral to the area of the pathway. So the 2 more. This is what I was trying to say. Here you are seeing you have 2 A's and a V. Cardia is continuous. One block with a This can happen in an AV and RT. Again, after this, as we talk about, as I said, other menus, whether you have a A or B, you have a A or B, either AV and RT. If you have a which is separated, less than 70 milliseconds, you can either have AV and RT or an AV RT. You can either have AV RT or AV and RT. And if you have a VA which is more than 70, then you either have an atypical AV and RT or a pathway which is a little decremental, known as a PJRT, paroxysmal junctional reciprocating tachycardia, and an EAT. The third one also says, but I'll try to make it simple to understand the day-to-day practice. So concentric activation during tachycardia, as I said, almost a VA tachycardia. So only two DDs, junctional tachycardia, AV and RT. Best way to differentiate, if you have the mode of initiation, AH jump, you are sure it's an AV and RT. But if you have other thing which you can do is to put in a early or a late APC, atrial premature contraction, which will make the find the fast pathway already engaged. So it will break an AV and RT, but it will have no effect on the JT. Concentric activation once again, you have a short RP, which is more than 70, or what you can call as a long RP tachycardia. Our two differentials stand here, atypical AV and RT and a PJRT. Best way to differentiate, since it's between a pathway and a AV and RT, you can use a His refractory VPC or a parahesian pacing. I'll explain how they can help. In a parahesian pacing, you're doing pacing at a high threshold and a low threshold. So if you have a pathway, it doesn't require any threshold. It will always use the same track. So your VA will remain constant, whether you have a high voltage or a low voltage capture. While if it's an AV and RT, if there is no pathway, with a high voltage, you will directly enter into the His. While with a low voltage, you will need to take the track, go from the right bundle, go to the apex and go back. So I'll show examples of parahesian pacing, but this is how you will concentrate if you have a long RP tachycardia. Now this is the example of what I said. If you have a ipsilateral bundle branch block, you see your VA has increased because it's a left-sided pathway. With the LBB developing, your VA has increased, but the tachycardia continues. So this is your sure that the bundle branch block on the same side, increasing your tachycardia cycle length, signifies that you have a ipsilateral bundle branch block. Now pacing during tachycardia. Now these are various maneuvers you can do, like resetting or a termination or an entrainment. Some of them I'll explain here. These are important. Atrial pacing during SVT. So you're talking about an entrainment. Automatic triggers will never have any entrainment because there is no pathway, there is no re-entry. You can have a VA linking. This is a very, very important phenomena. Now VA linking is there because you have a definite pathway. If it's an AV and RT or an AV RT, you have a definite track pathway. So the VA linking will stay. While in an atrial tachycardia, there is no VA linking. That means during tachycardia, if you would pace from two sides, differential atrial pacing, and look for the return VA, that will be well separated in an atrial tachycardia, but it will not be well separated in an AVRT and RT because the VA track is same. So I will show it in this method. You see in an ORT, AV and RT, your retrograde path is same. So even if you're pacing from different sides, the way to go from ventricle to atria is almost the same. So your VA will stay less than 14. While if you, in an AT, because you have no definite path from V to A, so this track can change and you will have a VA which is more. For an example, you can see here, just appreciate after the pacing, the VA which has come. If the VA is less than 14, you see the differentiation is 254 and almost same in both sides of pacing. It's a pacing from the right atrial appendage and the right free wall. So this is likely to be, because the VA track is almost the same, this is almost same, likely to be AVRT, AV and RT. Now appreciate this. You have a differentiation between 174 and 250. So here you have a difference of more than 14 because it's an atrial tachycardia. So your return cycle length changes because you have no definite VA. Diagnostic maneuvers during tachycardia, that means a ventricular pacing. You can do a resetting. The most important is His refractory VPC and entrainment. So I'll concentrate on these two, the His refractory VPC and the entrainment. Now, most important thing, you deliver a His refractory VPC.
Sanjeev,
since ventricle is not a part of your circuit, so AV and RT will not be affected. While an AVRT either can be advanced, or it can be delayed, or it can even break. So let's go to the examples because I've been asked to hurry down. Again, the same thing is happening. Now this is a very good slide which will just show you that you have introduced a ventricular extra stimuli and you have no change in your tachycardia. It's continuing because ventricle is not a part of the circuit. So what is happening is that your ventricle is the ventricular excess systole has nothing to do with the circuit. So it will have no change. While if you have a ventricular excess systole which comes for an AVRT, of course your tachycardia cycle length will be changed. But the phenomena is of advance and resetting. Advance means you have a which sets in earlier. Reset means that your VV will also reset. So advance doesn't mean there is an ORRT because advance can be just a bystander pathway. So the response has to be advance and reset, means not just the advance of the A, but the resetting of the VV cycle also. So next I want to tell you was just to concentrate on a simple thing that's known as the SAVA and the PPI TCL, the entrainment. You have a particular cycle length, and with a lesser cycle length you try to enter into the circuit, and from there you try to make sure that you are able to see what is the return cycle length which has come up, that is known as a PPI, and the target cycle length which is already there. So subtraction of PPI TCL less than 110 and the SAVA which is less than 85 signifies more of pathway. Until unless I have this slide, I cannot explain.
Sanjeev, I think you go to conclusion because it's...
Pardon?
Go to the conclusions.
Okay.
Because this is going to take...
No, you can't, because these are important ones which you
I
can
know,
appreciate
but,
the examples. I don't know why it's not
Unfortunately,
coming.
in terms of time, we are much too over.
Time is already running, sir. Time is not running.
Fine. Even if you come to the concluding slides,
Yeah,
I'll
just
not
put
be able
on the
to
last
show you
slide,
because
please.
the slide is overlapping. So this was important, the parahesian maneuver, but again, still the slide moves. And some vagal maneuvers also, but again, I think the take-home message stays, observation in baseline interval is the basic. Observe you're having a short PR interval, observe you're having an HP which is negative. Then you have observations during the atrial and the ventricular pacing, as I said. You're able to do a maneuver so as to induce a tachycardia with a particular pattern, like an atrial extra stimuli with an AH jump, or you have a pre-excitation which is increasing, you're able to diagnose. Observations during tachycardia induction itself. That means when the tachycardia is being induced, your maneuvers like the ventricular, premature ventricular contraction or an entrainment maneuver. Observations during this tachycardia. The entrainment and the his synchronous VPC are the most important two things which you do in your lab to make sure that you are able to reach to a diagnosis. And the parahesian pacing is the one which you do in a sinus to diagnose. Let's say you're confused. And the most important confusion is you have a short VA, anteroseptal pathway to be differentiated from AV and RT. The best way is to do a parahesian pacing. With the high voltage, low voltage, if you have a pathway, the VA will remain same. But if it's there AV and RT, with the high voltage, you will directly catch the hiss. With the low voltage, you will have to go down while the right bundle reach the apex and go back. So you have a VA which will change.